special for me to introduce our last, certainly but not least, speaker today, Josh Mailman. And used to say, yeah, Josh is everywhere, but I think this last year I've come to appreciate how much everywhere he really is. And he leads the Northern California support group, NorCal Carcinoid. He's president of that group. But he does so much more, and I think when you received the Warner Excellency Award in January this year, and Dr. Bergsland did the introduction, I really even more came to appreciate all the great things that you do for us, Josh. It's great to know we have someone who's so committed and so passionate and so smart and able to contribute, working for us worldwide, literally, and helping everybody figure out how these drugs can come to the market, working with the patients, understanding the science behind it, understanding PRRT so well. And so it's my pleasure to introduce Josh Mailman for a couple of other things.
Hi, thanks for staying. I think I forgot my presentation because I just let it all go in the last session, so hopefully I'll remember some of it. I'm going to bring you back. We're going to end this session or today with really looking back at neuroendocrine tumors again. I'm not going to do much in the mindfulness or living with, but I wanted to put up a couple more things. Yes, I'm from Northern California. We believe strongly in strength in numbers. We'll talk a little bit about that as my talk goes on. So here's the agenda. I said I would talk about a couple more things. I will talk about me, thing 1, thing 2, thing 3, and thing 4. They'll be presented when they come out. So I'm often asked to talk about perspectives about being a cancer patient or being someone with a rare cancer. So let me give you my perspective. Cancer sucks. We can get over that right now and talk about some of my observations on being on the road, working in this rare cancer space and working with a lot of the people you've heard from earlier today. I'm going to do a little bit about me, give you an idea of where I come from. Yeah, this thing's a pointer too. I was a blind pickup in September of '07. I did not have any symptoms. I developed those later along in my diagnosis. I've had 12 or 14. I've lost track of the number of Gallium-68 scans I've had at this time, which is why I'm so interested in Gallium-68. I've had my first PRT in May of '09. I've subsequently had 4 altogether so far. I joined my first medical society, which was a Society for Integrative Oncology in '09, and since then I'm on a lot of different medical boards. Besides my own group, I'm part of the outreach committee for the Society of Nuclear Medicine and Molecular Imaging. I'm on their patient advisory board. I am the Chief Operating Officer of WARMTH, which is the World Association of Radiomolecular Therapies, NCI, Task Force. I'm also the advisory board of LACNETS, and a couple other things. I do have a few conflicts. NorCal Carcinoid does receive money for various activities. We don't receive a lot of money. If you really want to read my perspective, the Journal of the NCI has one of my perspectives written there. There's also ASCO Post. There's a few other places you can find it. Enough about me. Not that. Thing 1. So I've been listening today and actually updating this presentation as we've been having this discussion. We've heard a lot of slides about how rare this disease is, but then Eric pointed out that he has a friend that, one of the singers from Phish has had 2 people around him who've had this disease. How rare can this really be? So maybe we're a little less rare than we think we are. This is good and this is bad. So let's talk about it really quick. The real words are incidence and prevalence. Yeah, the incidence of this is really rare. Then that means the number of times this happens in a year. Okay? So the incidence, and this is true, it is one of the fastest growing in the SEER database, but we'll talk about that in a second. The incidence between 1978 and 2004 has gone from 1.9 to about 5.25 per 100,000. Kind of for just really getting it into perspective, that's about 1,600 people in California this year will get diagnosed with NETs. Puts it in perspective, it's a real number. We talk about the incidence increasing and it's a fast-growing cancer and maybe there's something going on. Maybe we're getting better detecting it, but probably one of the other things that's happened besides we're getting better at detecting it is we're actually starting to record it. One of the things that I do is sit on the NCI Task Force for NETs. I also sit on the NCI Patient Advocacy Task Force. And one of the things that happens in the SEER database is your oncologist gets a note and says what type of cancer this is. Well, we still talk about cancers on the primary organ. And even when I'm on NCI phone calls, I still hear cancers described by the primary organ. We're getting better at doing things like marking down that it's neuroendocrine tumor, not just pancreatic cancer. And so this also starts bringing up the incidence because we're actually recording things properly. So that's one reason that it may be so fast growing. The other is we're actually getting to a much earlier diagnosis. The real number is prevalence. And prevalence is how many cases are there of this disease? So in 2004, it was 35 out of 100,000, about 103,000. But the number looks like it's trending up to 150,000 in the US. So why does that matter? Well, at 200,000, this disease is no longer rare, at least in the terms of the orphan drug statute, which many of our drugs get approved on. Matter of fact, on the bottom are the list of drugs that were recently approved of orphan drug. It's a lot easier to get drugs approved using this orphan drug status because you get smaller trial designs, reduced costs, maybe even some grant money. So we're not as rare as we think we are. In Europe, it's about to cross over whether or not it's still an orphan drug or not. And in Australia, parts of this disease are no longer an orphan drug. By the way, I did meet Eric in the airport lounge, and he did a little cut with his scalpel. No, just kidding. Had a trigger release surgery, so everything is fine. Obviously, I'm using it, but wasn't quite Eric with the scalpel. All right, thing two. Already done. Thing two is choice. We've heard a lot about choices in today, and I want to talk a little bit about choice. And maybe what we really want, and we've kind of heard a little bit, is we want freedom from choice. I think what we want is a clear path, perfect diagnostics, and a cure. We don't have that. What we have, and I just want to bring home that point again, is more choices and not necessarily clear paths. So in 2007, when I was diagnosed, I think, Ed, you did a great slide earlier this morning. There was one drug that had been really released in the last 20 years. There was one specific imaging agent that had been released in 20 years. In 2016, we had 3 drugs approved, new drugs since then. We have 2 in the pipeline ready for approval, and 1 imaging approval, which is NetSpot. We have more options, but no real clear paths. And one of the things that we're guilty of doing, and sometimes, and I saw it earlier today, is we like to cross-compare clinical trials. And this is really dangerous unless you're comparing trials that were conducted under the exact same thing. I put up ProMid versus Clarinet because one of the real fascinating things, if you look, both Sandostatin LAR and lanreotide were compared to a placebo arm of people who didn't get treated. But progression-free survival of that arm that didn't get treated varied by almost a year. So clearly, the entry requirements for those trials, how they determine progression, really determine how some of these things happen and why you can't make apples-to-apples comparisons. So be careful when you're making these kind of decisions on treatment and you say, well, this one, look how much better the progression-free survival. Unless they have the exact same entrance requirements, unless they're doing the exact same type of imaging or whatever they're using for progression-free survival, you really can't compare them. And it makes that much more difficult. Guidelines offer consideration of the path. We saw some of the guidelines, and yes, it said consider this, or consider that, or consider that. I think, Eric, you brought up the slide that had the final slide of like, there's 8 things to consider. There's no exact path. We saw certain models of treatment. I'll throw one more in. This is actually Iowa's how to treat a patient. So we are getting confused in that we have so many different ways to, after surgery and after somatostatin analog, all the different paths are different depending on who you're talking to. One of the things that I've been involved with for the last 6 years is Gallium-68. This is actually a map that I did up right before the second or right after the Second World Congress of Gallium-68 that showed all the centers in the world that actually were performing Gallium-68 in humans. There are a lot more that do it in animal models. In 2008, when I first was diagnosed, no center in the US did that. And Eric, you need to look up at your IND, but your first IND for Gallium-68 was in June 2011, not 2010. I like to make, I got to do the fact checking for you. In 2013, the first orphan drug designation for Gallium-68 was actually granted. I was a part of a team that worked on that. Obviously, we had the Netter 1 completed, and NetSpot was approved just recently. So we really have come a long way from really, when I first did this first chart in 2011, there were no spots for the United States. And now I'm going to have to figure out how to redo this chart. Okay, so that's me with a gallium generator. That's what we're talking about. That's a germanium generator that takes, you load it once a year, or you get one once a year or once every 12 months. You put a little hydrochloric acid on one side, and out comes Gallium-68. That's it. That thing, depending on whether it requires, there's several different types, but it's between $30,000 and $80,000. It weighs 24 pounds. That's what we're talking about. So one of the things that we didn't talk, we talked a little bit about it, a couple hours versus a couple days. That's great. That's one of the real benefits, what this new choice will offer. It will offer change management. So we need to stand up. Everyone in this room stand up for a second. I want to drive this home. All right, everyone that's sitting where the dividing wall is, back where Eric is, sit down. Okay, so about this many of you will be able to be imaged by, would have been able to be imaged by Octria scan. Okay, those of you in the 2 rows behind the divider, you can join us and stand up again. So we've added some more people who will now be imaged with Gallium-68 because it's a little better of an imaging modality. All right, everyone, let's see, everyone before the light. Everyone after the lights, please sit down. These are the people that will have change management based on having the new scan. A lot of you sat down. It means nothing's really going to change in your diagnosis or your treatment, but all these people in this part of the room just had their treatment changed. That's how big this will be. All right, everyone except for the first 2 rows here, sit down. And even on that side, sit down. You guys are going to have your unknown primary detected. So you're going to probably have surgery and have a really big change management. This is how big of a choice it is. Okay, now everyone can sit down. We didn't talk about this. We talked about it a little bit. This is slightly lower risk than an Octria scan. Someone brought up millisieverts. This is on the order of 6 to 8 millisieverts. An Octria scan was on the order of 14 millisieverts. Now, this is probably not a huge deal because what we learned 2 weeks ago in the Society of Nuclear Medicine and Molecular Imaging is these things aren't really cumulative. They're independent events. They happen. There's a risk associated with them. Every time you take it, there's a risk, but they're independent risks. So yes, these are a little less risky every time you take it. I talk about worldwide availability of the generator. That's, I work in the world, not just in the US, and this generator will make neuroendocrine patients around the world be able to get better scans, because that can get shipped anywhere. It's good for a year. They can do it right in their centers, and it's not that much money. So this will really make the detection of NETs and actually the management of NETs much more possible around the world. So quick thank you list. I'll try to go fast. AAA, they got the first NDA or new drug application done for NetSpot on June 1st. Vandy, Eric does get credit for having the first IND done, but also Iowa right after. I was part of a Gallium-68 working group that met every month for 4 years to try to harmonize all these INDs that were popping up around the country so that all the data could be used for submissions. Bonnie Clark, who actually leads the Clinical Trials Network for the Society, was key in keeping this all together. Johns Hopkins and SNMMI for hosting the third Theranostics World Congress in March 2015. Why was it important that that happened? Well, the FDA was there and 70 patients stood up and said how important it was, and the FDA listened. We'll talk about that in a second. All right, one other observation I meant just after going over there was a lot of people that you never heard of that were working on this to get this through. We, for the most part, hear about the docs that were in this room or that attend the conference. What really happens is most of the work gets done down here. There are thousands and thousands of people who are working on your behalf that we don't even know about. And you should feel good that many people are working on behalf for containment of this disease and a cure. But I want to also say that choices can be taken away. And one of the real important things we heard, and we kind of heard it here a little bit, was that PRT is available or approved, and it really isn't in Europe. Well, it was practiced in much like an investigational state that we do here, much more widely available, and yes, hugely available in Europe, but choice can be taken away. Without approval, last year, PRT as an option for many of the patients in the UK was taken away because there was no randomized control trial down, and it had not, been approved by any agency. So as much as we say things are available and why can't we all just go somewhere, the reason that approval is so important is it's harder to take away access once we have good randomized control trials and what access is, and once these things are in common practice. Thing 3, education. I should be able to finish up soon. Education is still key. We did, Giovanna was at the event in San Diego, so were many of you. We did a pre-event poll on how many people thought that scans are safe for you. And over 50% were on the side that said, not so sure. Okay, and after an education day where we talked about the safety of scans and what scans do, pretty much no one felt that they were unsafe for them. And we also asked that number about how many of you track your scans. About 52% of you do. It's good to have those as a backup. You should be, as was noted earlier, less worried about the amount that you're getting as long as it's the right scan at the right time. I do some other things, obviously, with many of you know me from prtinfo.org. Again, we seem to be inquisitive. We ask a lot of things. When I started this site, I really thought a couple hundred people might visit it once or twice, and that would be it. About 15,000 people come to it a month. They do amazing things in the search box looking for things. I'm usually blown away by it. I think I said I was going to make 4 things, so this is thing 4, making a difference. So first of all, money's good. But money's not the only way to make a difference. But for those of you who can donate and can help fund research and can make it happen, that's really great. As Ron pointed out yesterday, we were at the Peterson Museum. He is famous for Hot Rod magazine. It was really gratifying to see what he enjoyed so much, and that his foundation has found it appropriate to help fund $15 million worth of research. That's great. Not all of us have 15 million, and I understand that because I don't have 15 million either. So even without money, we can make a hell of a difference. So first of all, let's see if this works. Clinical trials. How many of you have all been in a clinical trial? of any type. So you've made a huge difference. You've provided information and really sources to move the art forward, to allow us to figure out whether these things, these new drugs are going to work or these new imaging modalities are going to work. So that's one way to participate. This was presented last week at a CME session in San Diego at the Society for Nuclear Medicine. An individual can make a difference. I've sat on 4 Nuclear Regulatory Commission meetings to try to get that generator that you saw declassified from being something that someone has to write a plan to how to decommission a site that has one. It's really silly. They're not particularly dangerous at all. They're sealed devices, but there's some problem in a guideline that was written 20 years ago. So having a patient voice on a Nuclear Regulatory Commission has helped them move this forward. One person, one voice made a difference. I've also, thanks to working with societies, we had meetings with Homeland Security on making it easier and more transparent for patients to actually come back after PRT from Europe. So about 2014, those of you who are on my mailing list got a note that the Department of Energy was about to get out of the manufacture of germanium-68. Most of you have never heard of germanium-68, but it is the thing that actually makes gallium-68. And without it, as it turns out, you can't get gallium-68, and the government, the Department of Energy, provides over 50% of the germanium in the world. And they were thinking of exiting the business because they're not in the business, but they're there to supply it if no one else will. Well, they decided they wanted to get out of the business. And if you followed my newsletter, and many of you do, I said we needed to write a letter to the Department of Energy. They got the most letters from patients ever for any medical isotope from this group. Because of that, the Department of Energy did not get out of the isotope business, or out of the germanium-68 isotope business, and they're still providing over half of the germanium-68. You guys made a difference. Lastly, I brought this up previously, but patient involvement in the Theranostics World Congress was so key to helping move both NetSpot or gallium-68 dotatate forward, that immediately after that meeting, within a week, basically they said they would extend any of the INDs that any of these centers were doing in order to make sure that gallium-68 wasn't taken away after the clinical trial was done. If a center wanted to continue, all they needed to do was say, I want to extend. And the other thing they did was say, send us an NDA. We really want to approve this. We understand that how important it is for patients. And again, thankfully, the AAA was able to do that and get it approved in, I think what Eric would admit would be record time, from the time to start to finish. So this is my part of my group. On our Strengths in Numbers, we do a running festival every year as part of the Oakland Running Festival. And I do believe that we are strengths in numbers. However we can participate and actually contribute is the way that we can move this forward so that we get closer to a cure and closer to not having, well, not necessarily having to come to this conference to learn about what the next thing will be, because we'll have it. So thank you very much for your time.